Sir, we can start. Ankit sir,
Yeah,
over to you, sir.
Okay, thank you, Ramdev. So, welcome everybody to this case-based panel discussion on CRPS of the upper limb, hosted by Academy of Pain Physiatrists. Let me introduce to you our presenter today. Our presenter is Dr. Megha Bhargav. She is a junior resident in Department of Physical Medicine and Rehabilitation in AIIMS, Jodhpur. She will be presenting this case. And our panelists, there are two panelists. Number one is Dr. Samriddhi Nanda. Dr. Samriddhi is basically professor in Department of Anesthesia in SMS Medical College, Jaipur. And her area of interest are pain medicine and regional anesthesia. She has done her fellowship in international pain management from AIIMS, New Delhi. She also has the degree of EDPM and EDRM. Our second panelist is Dr. Preeti Soni. Dr. Preeti is an assistant professor in Department of EMR at JLN Medical College, Ajmer. Her area of interest are holistic pain management and regenerative medicine. She has also done her FIPM from AIIMS, New Delhi. So I welcome all of you three, and to all the listeners. Over to you, Dr. Megha, for case presentation. Can you start?
Thank you so much, sir, for the kind introduction. Good evening, everyone. I am Dr. Megha Bhargav, an academic junior resident in the Department of Physical Medicine and Rehabilitation at AIIMS, Jodhpur. I'm going to be presenting a case of complex regional pain syndrome, that is CRPS, of the upper limb. The case details are as follows. It is the case of a 30-year-old male residing in Nagaur, Rajasthan, who is married, right-handed, and has received formal education till class 10th. He was a factory worker in his pre-morbid state and a Hindu by religion. The chief complaints of the patient are weakness, pain, and swelling in the right upper extremity for the last 4 years. History of presenting illness. The patient is a known case of polytrauma and right brachial plexus injury due to a road traffic accident which occurred 4 years ago in March 2020. The patient was taken to a private hospital where preliminary investigations and treatment was provided. The patient was told that he has sustained multiple fractures and some nerve injuries, which were fixed with plates, and nerve repair surgery was done as per information provided by the patient's brother on the next day of the accident. The patient regained some active movements and power in the shoulder, elbow, and wrist about 4 to 6 weeks post-operation. A few weeks after the operation, the patient started complaining of pain in the right upper extremity, which was particularly more in the right arm and the wrist. Onset of the pain was not well defined, however, it was diffuse, continuous, gradually progressive, which later plateaued, burning and electric shock-like in nature, severe in intensity, and had no relieving factors. The pain aggravated on pressing the arm and passive movement of the elbow, wrist, and fingers. The pain scale on NRS score was 8 by 10. The patient also complained of swelling and redness in his right hand and distal forearm, and also said that his right hand felt hotter than the left one. The patient also complained of decreased sweating in his right hand. There was no diurnal or postural variations in the swelling. There was no history of tingling, numbness in the right arm, any neck pain, giddiness, or fever. The patient had consulted multiple doctors, but there was no improvement in his symptoms in all the treatments that were provided. Finally, the patient presented to the Department of PMR at AIIMS Jodhpur 3 months ago. Functional history. The patient is independent in feeding, toileting, transfers, locomotion, sphincter control, communication, and social cognition. The patient was, however, dependent in dressing and grooming. Past medical and surgical history. There was no history of any similar complaints in the past, any chronic medical illness like hypertension, diabetes, any thyroid abnormality, tuberculosis, or prolonged hospitalization pertaining to any medical or surgical condition apart from the present condition. Family history. The patient lives with his family, his son and daughter, and there is no history of any chronic illness running in the family. Personal history. The patient is a vegetarian by diet and has a normal appetite. The patient experiences sleep disturbances, that is increased sleep latency and shortened duration of sleep due to pain. There are no known allergies, and the patient used to consume alcohol occasionally in the pre-morbid state. Vocational history. The patient was a factory worker. Currently, he is unable to participate in his work duties due to weakness in his right hand and the severity of his symptoms. Psychosocial history. The patient is distressed by his condition and the lack of treatment despite consulting multiple doctors. He's not aware of the diagnosis currently and the nature of his disease, but he hopes for a complete recovery. Examination. The scheme of examination was explained to the patient and verbal consent was obtained. The patient was examined in the sitting position. The journal physical examination was as follows. The pulse rate was 92 beats per minute. The BP was 138 by 82 millimeters of mercury. Respiratory rate was 22 breaths per minute, and SpO2 was maintained at 99% on room air. There was no pallor, icterus, cyanosis, or clubbing. The higher mental functions were intact. The cranial nerves were also bilaterally intact. On neck movements, there was only stretching type of pain in the right side when the neck was laterally rotated or flexed on the left side. On inspection, I'd like to show you the pictures of the patient. As you can see, that the right hand appears to be swollen than the left. The skin is also reddish in color compared to the left, which is the normal limb, and the skin appears to be shinier than the left limb. When asked to flex both of his hands and make a fist, the patient was able to do so on the left side, but not able to do so on the right side due to decreased range of motion and stiffness. On palpation, there was local rise in temperature on the right side. The right hand and distal forearm were diffusely tender. On the examination of the scar, there was no scar tenderness or any adherent tissue underlying. The range of motion was decreased in the right shoulder and right elbow, both actively and passively. Passively, the patient did not allow to move his right wrist. However, actively, he was able to flex it till 5 degrees. The active and passive range of motion of both fingers and thumb was also decreased. On testing of the prehensile function and hand grips, the patient was able to perform the spherical and cylindrical hand grips. However, they were weak compared to the left side. The patient was not able to perform lateral pinch, three-jaw chuck, or hook. On neurological examination, the bulk of the right midarm and right forearm was more than the left one by 1 and 1.5 centimeters. The tone was normal in both the limbs. On manual muscle testing, the patient could not be tested on shoulder muscles because the range of motion was severely decreased. The power in the left shoulder was 5 by 5, which was full. The power in the elbow on the right side was 4 by 5 in the available range and 5 by 5 on the left side. In the thumb, fingers, and wrist, the power was 3 by 5 on the right side, that is the affected side, and full on the left side. On wrist, it was not testable due to severe pain. Sensory examination. On the right side, light touch was hypoesthetic in C7, C8, and T1 dermatomes of the right arm and forearm, and dysesthesia was present over the dorsum of the right wrist. Light touch was intact on the left side. The hot temperature was perceived as pain, whereas cold was intact on the right side, and both were intact on the left side. Pinprick was also perceived as pain on the right side, and it was intact on the left side. Vibration and joint position sense were intact bilaterally. Stereognosis was intact bilaterally, and additionally on the right side, allodynia was present and sweating asymmetry was present as it was decreased on the right side. On systemic examination of the cardiovascular system, respiratory system, and abdominal examination, it was fairly normal. The patient was admitted on our side and investigated.
Dr. Megha, 1 minute.
Yes.
So I'll ask one of the panelists. Dr. Samriddhi, you have gone through the investigations and the pictures and the history. So what would be your most probable diagnosis in this case?
So it looks like CRPS of the upper limb to me, considering that there was an inciting event of a 4-year history of multiple fractures as well as a nerve injury. And then he has, the patient also has a lot of symptoms, like the pseudomotor symptom is present, there is motor atrophy, there is sensory symptoms of allodynia, hyperalgesia is present, right? And there are nail changes also, there's edema present also, right? And there are signs also of the same. So this looks like CRPS to me.
Okay, thank you.
Yeah.
Dr. Megha, you can continue. What investigations you have gone through?
So the patient was admitted on our side and he was followed, he was worked up. The blood investigations were fairly normal, with only a slight increase in CRP, which was 6.9. These were the X-rays done for the patient. As you can see that the shoulder X-ray shows no bony abnormality. And on the X-ray of the right hand and wrist, you can see mild osteopenia, which might be related to disuse. Otherwise, there is no bony abnormality, which might restrict the range of motion so severely in this patient. A triple phase CT was done for the patient, which showed a markedly increased radiotracer uptake in the right hand and distal forearm. The radiotracer uptake was also increased in the right distal radius, ulna, with a predominant increase in the periarticular region of the right wrist and small joints of the right hand. The nerve conduction studies and electromyography of the report showed a post-traumatic post-ganglionic pan-brachial plexopathy. The CT and MRI report of the patient, which was present at the time of the accident before the operation, showed a fracture of the right distal shaft of humerus, right clavicle, a condylar fracture of the left mandible, and muscular contusions in the left sternocleidomastoid, right trapezius, biceps, and supraspinatus muscles. The dorsal root ganglia and cervical paraspinal muscles appeared normal with no evidence of any cord hematoma or pseudomeningocele, which shows us that the injury was not preganglionic, and all roots of the right brachial plexus were involved. Now, after working up the patient, we applied the Budapest criteria for CRPS, and I have highlighted the signs and the symptoms which were present in the patient. And as we can see that the patient had a continuous pain, which was disproportionate and extended beyond the natural course of the patient's condition. There was hyperesthesia and allodynia present, temperature asymmetry, as the patient said that the hand felt hotter. There were skin color changes, edema, sweating asymmetry, and decreased range of motion. And they were evaluated when the patient was examined. So they were present as signs also, just as ma'am said. So our probable diagnosis was complex regional pain syndrome, or CRPS type 2, in a known case of polytrauma and post-ganglionic brachial plexopathy secondary to a road traffic.
Okay, Dr. Mega, just a minute. So, Dr. Preeti, can you enumerate or tell us what could be the most probable other diagnosis which should be ruled out in this case?
Sure, Dr. Ankit. Am I audible?
Yeah.
Okay. The other differentials can be the persistent post-traumatic stiffness, and the patient may also have the post-traumatic neuralgia, but as the distribution is not in the distribution of the affected nerve, it is the generalized swelling and the edema, so it more favors towards the CRPS. The other differentials can be the patient may have the rheumatoid arthritis, and as the periarticular osteopenia is present, the pain is present, so the patient may have we should rule out all with the CRP and the RA factor, we should rule out the diabetic polyneuropathy or the post-traumatic neuropathy can be there. Osteoporosis, definitely it is and the osteomyelitis, we should also rule out these.
Okay, thank you. So, Dr. Samriddhi, can you tell me, is the type 1 and type 2 CRPS, there is any difference on the basis of investigations, what should be done? And in this case, would you want to add some other investigations?
I think Dr. Samruddhi is not audible.
Ma'am, you are not audible. Yeah.
Yeah. Can you hear me now?
Yeah, please.
Yeah. So type 1 is devoid of any nerve injury, and type 2 has a specific evidence of nerve injury. So in this case, it looks more like type 2 CRPS because there's a clear-cut evidence of nerve injury. And the second question that you asked was that whether the investigations and additional investigation would be required for diagnosing this condition. So mostly CRPS is a clinically diagnosable condition. Earlier, there used to be IASV criteria that was followed, but now a very sensitive measure was Budapest criteria, which Mega very nicely elucidated. So it has around 98% sensitivity. So for the screening, I think Budapest criteria is the best, and it is also specific to about 68%. Additionally, you could actually get done a bone scintigraphy, which was done in this case, but it's not conclusive, and there's not enough evidence to support it as a diagnostic modality. Also, you could do a bone scan for demineralization, but not at this is a chronic condition. It's not an acute condition. So bone scan would also show demineralization. EMG can be done. A QST could be done to just elicit the damage to the fibers, the kind of fibers. So whether it is the large myelinated fibers or whether it is the small unmyelinated fibers, the differentiation can be done through QST. Additionally, you could do a musculoskeletal ultrasound also, but all of these are not required for the diagnosis per se, but they can add on to the evidence of it being a CRPS.
So just a query. So is there any role, timeline for which you have to do this bone scintigraphy after 3 months of injury, 4 months of injury, or like in this case, it is almost done after 3 years, 4 years of the injury. So in this case, bone scan is helpful.
So earlier during the CRPS evolution, there is more inflammation. And towards the later part of the CRPS, that is chronic CRPS, there's more resorption. So I believe the bone scan should be done towards the later part because it's going to help you elicit the demineralization. Whereas scintigraphy should be done earlier because it's going to show you the areas of high inflammation.
Okay, thank you. So Dr. Megha, how was management done? Then we'll come to the management by our experts.
Yes. So the patient was managed medically with pharmacological and non-pharmacological modalities, and also by interventional management. The patient was planned for right stellate ganglion block and right suprascapular nerve block and shoulder hydrodilatation. Pre-procedure, the medications that were prescribed for the patient were a buprenorphine transdermal patch of 5 mg strength. As the patient was admitted, an injectable tramadol of 50 mg and ondansetron of 4 mg was also prescribed on an as-needed basis. Tablet of gabapentin 100 mg was given twice a day, and gabapentin along with nortriptyline 400 by 10 mg was given at night. A sachet of vitamin D3 60,000 international unit and multivitamin tablets were also given. In the non-pharmacological rehab protocol, the patient was given cryotherapy followed by gentle passive range of motion exercises, desensitization therapy, CPM for right shoulder, isometric strengthening of neck, periscapular muscular strengthening, contralateral rotator cuff strengthening, clay putty activities for the right hand, and activities for change of hand dominance as the patient was right-handed. The procedure was explained to the patient and the possible complications were also told to him. Viral markers were checked, non-reactivity was noted, a written informed consent was obtained from the patient, and a pre-procedure examination was repeated. The vitals were stable, and sensitivity testing for local anesthetics and ceftriaxone was done, and intravenous line was secured in the pre-procedure OT. This is the image of the right stellate ganglion block performed at C6 level. It was done via fluoroscopy guidance. Then a suprascapular nerve block on the right side were also done for improvement of shoulder range of motion and pain reduction. This is the picture of the ultrasonographic suprascapular notch where the suprascapular vessels can be seen via color Doppler and the drug is deposited in this notch. This is a video of shoulder hydrodilatation done for the patient via an anterior approach. And you can see the needle path here and also the drug going in the interarticular space. It was confirmed by Doppler. Post-procedure, the patient NRS was 1 by 10 and the vitals were stable. The burning and the electric shock-like pain that the patient initially had disappeared, and only mild soreness on the injection site persisted. The patient was made to sit up 15 minutes after the procedure, and meiosis and partial eyelid drop on the right side was noted, which subsequently resolved. Ice pack was applied on the right shoulder, and the patient was counseled regarding the possible danger signs and complications in the late post-procedure period. The post-procedure rehab protocol that was followed was the tablet aceclofenac of 100 mg strength was prescribed twice a day for the 2 days, and then on an as-needed basis, tablet gabapentin and nortriptyline was continued at night. Multivitamin and vitamin D was also continued. Ice compressions were given for the 3 days after procedure. Manual manipulation for shoulder range of motion was done in the OT after hydrodilatation. Contrast bath was prescribed for the swelling of right hand. Desensitization therapy and CPM was continued. And rest of the exercises which were prescribed in the pre-procedure period were also continued, along with ADL retraining and cardiopulmonary endurance training, which were added later.
Okay. Thank you, Dr. Megha. We'll come back to how
Yes.
the patient perform. So, Dr. Preeti, I generally want to ask you, in this case, the CRPS, as we know, could be acute and chronic. So, what could be the pharmacological management in acute case?
Dr. Ankit, when the patient present with us with acute CRPS, then the pain and the swelling. The edema is the most presenting complaint. So first we have to respect the pain, and we have to treat, or we have to do all the intervention to treat the pain. The pain interventions and the treatment should be started as soon as possible, as the guideline says, and the psychological and the rehabilitative treatment, it goes parallel. In rehabilitation, we should always respect, if the patient pain threshold, the pain is severe, then we should always respect the pain, and we should give the oral or IV medication and the intervention to relieve the patient's pain. And if the pain is severe, then and the patient present with intense pain at the rest, then the rest should be given to the affected extremities. The contralateral limb physiotherapy should be started, and the sympatholytic blocks and the oral medication in the form of the opioids, the gabapentinoids, should be started to the patient. If the pain is moderate, like the patient, there is no pain at rest, but the pain is there in the movement, then the pain management, oral pain management along with occupational therapy and the physiotherapy should be started. And if there is mild CRPS, that there's no pain at rest, then we can go for the intense exercise therapy and the occupational therapy. The role of mirror therapy is also there, because there is neglect, some sort of neglect is there. But this mirror therapy should be followed in a sequence, like first the lateralization protocol should be followed, and then lateralization, and then the imaginary movement should be advised, and then the proper mirror therapy should be advised to the patient.
Okay. So, Dr. Preeti, is there any role of oral steroids in acute phase?
Yes, when the edema component is major, then the short-term use of the oral steroid, they are beneficial for the patient.
Okay. So, I think in medical treatment, what we can add is bisphosphonates. So
Bisphosphonates, yes, definitely.
we should add that in acute.
Yes.
Just so, Dr. Samriddhi, is the chronic phase treatment differs from the acute phase? We should add something, we should delete something. Chronic phase, basically after 6 months of developing CRPS, is there any difference in medical management, or we should directly go for sympatholytic blocks? Ma'am, your sound mic.
So sorry. So you can continue the gabapentinoids as well as amitriptyline. Although steroids are not required anymore because they are active only during the acute phase of inflammation. Bisphosphonates, again, not required. They are more active during the acute phase of inflammation. But if there is evidence of demineralization, ongoing demineralization, you could still carry on bisphosphonates. But by and large, we just continue gabapentinoids and painkiller medications, maybe NSAIDs for a short period of time. And if that doesn't work out, then we might like to go for some sympatholytic blocks.
So, which gabapentinoid would you prefer, or are there any difference in evidence between pregabalin, gabapentin, which should be preferred in CRPS?
Actually, there's no conclusive evidence of either gabapentinoid or amitriptyline, but it just has evidence in rebuilding up the sleep cycle. So, out of the two, I think I would prefer gabapentin over pregabalin out of the two for CRPS. Again, there is no conclusive evidence, and you could use either or, but my personal preference is that of gabapentin.
Okay. So, Dr. Preeti, we have a question from the audience, which on the rehabilitative approach. I want to ask, how is mirror therapy done? What is the basic principle in CRPS? Also, can you please, as we are a rehabilitation physicians, So when to start exercises and how to proceed with them in our OPDs for these patients. Can you shed a light on that?
Sure. As I have already mentioned that the exercises should be started only once the pain is managed. So if no intervention should be taken if it hurt to the patient. We should always respect the patient in the acute phase. And then the stepwise protocol should be followed. When the pain subsides to the acceptable level, then the passive exercises and the mirror therapy is useful. The passive stretching of, like CRPS is also known as shoulder hand syndrome. So passive stretching and passive range of motion exercises for the shoulder and the hand should be initiated. And these all should combine with the sensory desensitization and the lateralization program. And in the rehab, yes, the rehab has shown the long-term benefit in both in function and the pain. And the combination of the hand laterality program with mirror therapy, stepwise approach should be followed in these cases. And this level 1 evidence is there, level 1 degree B evidence is there for the mirror therapy in the patient with CRPS.
Okay, so in the physical modalities, is there any difference between cryotherapy? Basically, it is not cryotherapy, it is cold therapy, contrast bath and wax bath to be given to CRPS patients?
Yes, in acute phase, cryotherapy is definitely beneficial for the patient because it is the warm limb, which is a warm and water limb. So the cryotherapy is beneficial in the acute phase. But when the joint stiffness is there in the chronic phases, then I will go for the patient should be advised the wax bath therapy and to increase the range of motion.
Okay. And Dr. Samriddhi, there are increasing evidence for calcium channel blockers in acute phase. Are there any, what is your experience with that?
Calcium channel blockers, actually, I've never used. Are we talking about calcitonin instead?
No, like nifedipine.
Verapamil and nifedipine. Yeah, in chronic phases, you could use nifedipine. There is evidence, there is growing evidence of nifedipine. But in my practice, I've never used. But there is definitely an evidence of 10 milligram of nifedipine once a day. Because what they believe is that if you increase perfusion towards the limb, then the sympathetic mediation might actually decrease.
Okay. So, yeah. So, Dr. Preeti, can you tell me what interventions we can do? And are there any guidelines and evidence for those interventions, what we do?
Yes, there is role of interventions, and first we can do the sympathetic ganglia block as we have done in this case. In the upper limb, the stellate ganglia block has been done, and the level of evidence is level 1 evidence with the B degree evidence. So it is definitely helpful. The radiofrequency ablation or the phenol neurolysis may reduce the pain, but the level of evidence is grade C degree evidence, but level 1 and C degree evidence is there. Neuromodulation in refractory cases, neuromodulation and the spinal cord stimulation can be done, and it is also FDA approved for the CRPS. And the level of evidence is again for pain and functionality. It is the level 1 and B degree evidence is there. The dorsal root ganglia stimulation, it is also FDA approved for the CRPS, and it also can reduce the pain and improve the function. The peripheral stimulation, it is level B, level 2 evidence is there. So it is not highly recommended in the cases. The intrathecal interventions like the baclofen can be tried in the patient when the severe dystonia is present. The other level of evidence is only present for clonidine in these cases, which is beneficial for the pain.
So, so is there any difference in efficacy or difference in efficacy between a CARM guided and a USG guided stellate ganglion block? And also, is there any difference between type 1, type 2 CRPS outcome by stellate ganglion block?
The efficacy of fluoroscopic guided stellate ganglia block it is much better. But I usually prefer to do a USG guided approach, because we can see the vascularity of the because the neurovascular structures are nearby, so we can definitely see them better. But yes, if there is risk of subarachnoid and the epidural space, then injection, then we should always confirm the procedure with the fluoroscopic approach.
So as far as I think, type 1 and type 2 CRPS management remains the same. Only type 1 and type
Yes.
2 is due to involvement of nerve and non-neural involvement.
Definitely.
Right. So now, Samriddhi ma'am, is there any role of regional blocks in management of CRPS?
Well, regional blocks do have a role. So there are many studies that have been done on paravertebral blocks used for CRPS management. So the idea behind using paravertebral block, that is thoracic, the T2 paravertebral block, is that there are some nerves of Kunz that get missed when you do a stellate ganglion block. So there's one stellate ganglion block that she's already mentioned, Dr. Preeti has already mentioned. Then there is paravertebral block that may be effective, more effective than stellate ganglion block. Then there are other blocks like infraclavicular axillary plexus block also, infraclavicular brachial plexus blocks also. So these are the kind of blocks that may be effective, because by and large, if you give a lot of volume, then these are going to ascend into the spaces that are going to do a sympathetic block. So either you do a stellate ganglion, or you do a paravertebral, or you do a T2 sympathetic block, or you do an infraclavicular brachial plexus block. They are basically the same area, and they are going to affect the same sympathetic nerves. So yes, there is evidence, and there's more growing evidence about paravertebral as well as T2 sympathetic vis-a-vis the stellate ganglion blocks.
Okay. So can you shed a light on which local anesthetic and which steroids to be used in your experience are the most effective for stellate ganglion block?
So local anesthetic, you could use a lidocaine-based local anesthetic, or you could use bupivacaine or ropivacaine. It really doesn't matter, because basically what we're looking at a long-term treatment of this kind of a condition. So lidocaine, even if it has a duration of 30 minutes to 2 hours, bupivacaine is just a little ahead of it, like 3 to 4 hours. Ropivacaine, it is again having the same timeline. So it really doesn't matter, because it's going to just abate in a short time. But what really does matter is the use of corticosteroids. So what we use methylprednisolone. We could even use triamcinolone. There is evidence of depot preparations of all of these steroids. People have also combined clonidine, thinking that there would be a little bit of vasodilation alongside. But if you compare them together against methylprednisolone, there is no substantial advantage of using both of them together over just using steroids.
So Dr. Preeti, how frequently these blocks can be used? You have any experience in that? To break the pain cycle, how many blocks are required, or how frequently that block should be given?
Dr. Ankit, in our practice in AIMS, we have given, like in severe cases of CRPS, we have given the block repeated even after 3 days. But in a few days, like in other cases, we can repeat it after 1 week. So, and
any difference between particulate and non-particulate steroids, which should be used, and what should be the risk factors should be borne in mind when you use particulate steroid in these cases?
Yes, the efficacy is same for both particulated and non-particulated steroid, but yes, the risk of vessel blockage with particulate steroid is much more. So better use a non-particulated steroid like dexamethasone for the patient with CRPS.
Yes,
I agree with Dr. Preeti a lot, because there is more evidence of using a non-particulate steroid now than using a particulate steroid. I agree with that.
As an interventional pain physicians, we have to always bear in mind the complications which can happen with such high-risk blocks. So can you tell me some of the complications which we can go through during, which we should be aware can happen during these blocks, and in short, how we could manage them immediately?
So there are a lot of complications. If we talk about the stellate ganglion blocks, so there could be complications that are vascular related or nerve injury related, or they could be damage to the viscera. Also, there could be transfer of the medication into the intrathecal space, which is so not desirable. There could also be local anesthetic systemic toxicity, which is last. So the vascular injuries can happen, like we very well know that where we are targeting, even under ultrasound or without ultrasound under fluoroscopy guidance, we are targeting it the needle just behind the carotid. So there's obviously a chance that we puncture the carotid. So while we are puncturing, we sometimes have to go through the IJV. Even if we compress it fully, there is a chance that we are actually going through and through, and there is a chance to damage to the IJV. So there's also a dorsal scapular artery, which is very commonly encountered in brachial plexus blocks per se, but you can also puncture dorsal scapular artery here. So there is also a chance to damage the vagus, the recurrent laryngeal nerve. These nerves can be damaged. Then there could be a puncture to the pleura. There could be pneumothorax. There could be puncture to the trachea, to the esophagus. All of these can be managed. So it is very difficult to, to manage if there is the subarachnoid transfusion of the drug. But otherwise, all of these vascular punctures can just be plain and simply be managed by pressing at a local site and just holding it up for the next 5 minutes. Obviously, the visceral damage, the visceral pleura and visceral pleura damage, that is the pneumothorax that is created, will be diagnosed a little later after 2 hours of continuous poking. Or if you are using a very large gauge needle only, then you will be able to damage pleura sufficiently to create pneumothorax. So that's not much of a concern. However, this can happen. The last can really be very catastrophic. This is by far the most. Alongside, even the subarachnoid blockage could lead to total spinal anesthesia. That is also, in my opinion, that is rated very high in the type of complications that are really requiring a very intense management. So if you have encountered a subarachnoid blockage, then you probably, because you're giving 5 mils of the local anesthetic plus the steroid, so you might have to support ventilation. You might also have to give a CPR to the patient at times. You might have to send the patient on a ventilator, do some proper ICU management. In cases of last, again, there are 3 pillars of management, as in there should be a seizure management, there should be an ACLS protocol instituted, and 20% lipid emulsion in the required dose. So these are the managements that these are the things that you should keep handy while you're managing a case of CRPS through a stellate ganglion block.
Okay, I have seen a few of them, carotid sheath block. So vagus was blocked. There was sympathetic overactivity. Patient have to be shifted to ICU because of the rising BP, and has to be managed on IV labetalol for few hours.
Wow.
That
Yeah.
I have seen while doing an ultrasound that touched the C6 root. So it gave a temporary weakness and a severe pain in already painful upper limb. So I always prefer that this block should be ultrasound guided because there is a live visualization of the tissue. The needle is passing from which tissue, so you can see it very clearly.
Absolutely. There's a real-time visualization of wherever you're going and however you're going. Absolutely.
So Dr. Preeti, do you have any experience on using alpha blockers like clonidine or something? Whether they should be used firsthand or they should be used in the patients who have been given multiple blocks and the effect of steroid and local anesthetic are decremental, अब इतना पेन कम नहीं करते हैं, उन पेशेंट्स के लिए हमको क्लोनिडीन रिजर्व करना चाहिए और इट शुड बी स्टार्टेड इनिशियली.
Yes, alpha adrenoreceptor blocker like clonidine can be given with the interventions, and the result of clonidine is better, and it can be combined with the local anesthetic and the methylprednisolone.
Okay. Samriddhi ma'am, do you have, is there any role of ketamine infusion for management of this CRPS upper limb pain, which we give IV ketamine?
Yeah. So in very, very refractory cases who are not being able to be managed through blocks alone, we would, there is more evidence of neuromodulation as against ketamine. But of course, neuromodulation has its flip side. There is more investment into it. There is more money involved. So one spinal cord stimulator, actually, I think it is some 15 lakhs or 18 lakhs or something like that. So considering that, I might want to switch to IV ketamine. And there is a role, but it has a role only for short-term benefit.
Okay, so it can be combined with the blocks.
It can be combined with the blocks, yeah. It can be combined with.
So in what dose should ketamine infusion and how it should be given? Can you tell us?
So if you're aiming for an IV ketamine, then I'd like to start it as a bolus of about 0.5 milligram per kilos, and then a continuous infusion of about 0.35 milligram per kilo per minute, per hour, sorry, 0.35 milligram per kilo per hour, and run it for at least 4 hours. And this I would like to do for the next 10 days. So there has been evidence that ketamine actually, because through neuromodulation, through NMDA antagonism, it has been able to reduce the pain. So people have gone from 0.15 milligram per kilo to right up to 7 milligram per kilo, very, very high doses. And it has been able to abet the symptoms to up to 4 months. But then they say the pain also recurs and it's not a long-term management. At best, it's a short-term management.
Okay. So Dr. Preeti, when the block should be repeated, is there any evidence or literature how frequently block should be repeated, relating it to motor symptoms like movement of fingers and shoulder?
Though there is no any evidence of repetition of the block, but it is repeated until we have the pain, because the pain component and the swelling component, it is mainly taken care by the stellate ganglia block. So when the symptoms are present, we have to repeat the block.
Okay. And is there any role of IV regional anesthesia for CRPS?
Intravenous regional anesthesia for CRPS, like the risperidone, and they are present, but the level of evidence is it is for short term for pain relief only, and the level of evidence is level 2 for these.
Okay. And have you done, there are a lot of things which are coming into market, like shockwave therapy, dry needling. Is there any evidence for those things?
The acupuncture or the dry needling, there is level 2 evidence for the CRPS. And for shockwave therapy, there is no evidence is mentioned in the literature.
Okay. So I think what I want to ask is, I think good enough. What is your experience in how frequently, importantly, which came into my mind, how frequently CRPS is misdiagnosed or not diagnosed by other faculties? I would like to ask you both, because you both are running independent pain clinics at respective hospitals. So how frequently it is misdiagnosed? Dr. Samriddhi, can you?
So it is largely misdiagnosed because, people have been treating them with God knows everything under the sun, all right? And they have even sent the patients to psychologists, to therapies, to psychiatrists, and they have been labeled as Munchausen syndrome and they've just been sent away. So it is pretty sad because CRPS is real. CRPS is real, and it is it is commonly missed because it's not very well focused in medicine practice in India. So I have seen one patient who actually was told that तुम्हारा पेन घूम रहा है, right? Because he would start having pains and he would be so miserable, and he was constantly for 2 whole years he was given opioids, starting from tramadol to buprenorphine patch and whatever not, and finally he was labeled as Munchausen syndrome and just was checked out of the clinic. So it is pretty sad that things are happening. So let's say that there is at least 20% people who should have been diagnosed with CRPS and are never diagnosed. Maybe that's an understatement in my practice. Maybe Dr. Preeti can throw another light on another kind of instance that she has.
Yes, doctor.
Definitely, ma'am. The CRPS is highly misdiagnosed, and people, they treat them as the post stiffness, the neuropathy, even the lymphedema, and many more. So, timely diagnosis of the patient is utmost important, and the timely intervention for the pain and the rehab.
So yes, so basically your mind knows what your eye sees. Yeah, your eye sees what your mind knows. So you have to be, as a pain physician, very alert for CRPS, both for upper limb, lower limb, as well as I have seen some local CRPS after knee replacement around knee, which have been
Absolutely. I've seen that too.
that has been misdiagnosed as a loose joint or anything like that, stiffness or like that. So simple, some steroids and pregabalin, gabapentin would help them a lot. So I would ask Dr. Nitesh or Dr. Sanjeev, do you have any questions to ask?
Yes, Samriddhi.
It was excellent. It was an excellent meeting today.
Basically, hello,
Yeah, Dr. Sanjeev.
am I audible?
Yeah.
Hello. Dr.
Yeah,
Sam,
you're audible.
I have basically one question. What is your experience in stellate ganglion block? Basically, I've seen even it responds in 70-80% of cases. Okay, if this patient is not responding to the stellate ganglion block, what are the other options you are looking for the management?
So, very simply, first of all, I would like to go in for a paravertebral block. It is easily doable. It can be done under ultrasound guidance, and it is mostly a bedside procedure. So my next step of management would be, if SGB is not working, then I would go for a paravertebral block. If not that, then I would like to do a fluoroscopy guided at T2 sympathetic block.
Yeah.
So that's going to be my next steps in management.
Ma'am, there is any role of T1, T2 epidural steroids?
Not that I know. Epidural steroids can help because eventually they are going to block the sympathetic nerves only. But I have not seen it in the literature so far.
Yes, Dr. Sanjeev. Yes, Sanjeev.
It was a very yes. Am I audible?
Yeah.
Yeah.
Yes. So it was a very nice discussion amongst the panelists and the moderator. So I think we have covered the most, or I think whole of the CRPS in this webinar. So I don't think anything has left. There's a role of neuromodulation, the role of spinal cord stimulation is coming up, and there's a lot of evidence on that. But we don't have any experience right now because we have not performed right now. But in the coming years, we will perform this DRG stimulation and spinal cord stimulation. Then we can also able to speak with our confidence and experience. Thank you. Thank you all.
Absolutely.
Okay. Thank you. Thank you, Sanjay. So with this, I take a permission to permit. Thank you, Dr. Megha, for an excellent case presentation. Thank you, Dr. Preeti and Dr. Samriddhi, for your enlightenment on this topic. I know we have done it together in AIIMS OPD. Yes.
Yeah, it was lovely, Dr. Ankit, and thank you for inviting us over. It was very, very well comprehensive, and very nicely touched, very nicely moderated, and very nicely presented as well. And it was nice knowing Dr. Preeti, and it was nice knowing that there are 45 participants in this webinar.
The participants number have reached up to 51, 52 also in mid meeting also. So it was a very good gathering. It was very good gathering.
All right, that's very, very encouraging.
CRPS is such an elaborate topic now, you can discuss it for hours.
Absolutely, I agree on
Right
that.
from diagnosis to symptoms and to management, I think has to be worked with more diligence. Okay.
Yeah.
For the student also, it is very important to know how to diagnose the CRPS, because it is totally a clinical entity and the clinical diagnosis. So knowing all the signs, all the symptoms and the criteria, it's very important to know for the students.
Still, for those who are still with us, can we give some prophylaxis so that CRPS doesn't develop, and when and how much it has to be given?
The role of vitamin C is there in the prophylaxis, and the dose is around 500 milligram per day when the fracture occurs or any sprain or occur. And yes, there is also role of perioperative sympathetic ganglion block in the patient with upper limb trauma who are undergoing the surgery. These two are the present till now for the evidence.
So
we could also give some topical ointments like DMSO creams, as well as
DMSO cream, amla cream,
for hyperalgesia.
Yeah,
absolutely.
Vitamin, they can also be used, but these are for the treatment, not for the prophylaxis.
Yeah, that's right.
That's right. Prophylaxis is with vitamin C.
With vitamin C.
So basically, for all the trainees and JRs in PMR, I would like to ask कि जब orthopedics वाले upper limb का कास्ट निकाल के भेजते और बोलते ना पेशेंट को स्टिफनेस है, उसका हाथ नहीं चल रहा तो जरा देख लो, एक्सरसाइज करवा दो, then look if he or she has developed CRPS. So treating that early would be helpful to prevent the complications. That is my experience. I have learned it hard way. Right.
Sir, what is the role of TENS in managing CRPS?
The TENS, there is level 1 evidence for the TENS in the treatment of the CRPS, both for the function and the pain. So it can be started early in the acute phase of the patient, but not in the severe.
The site of the TENS, where should it be given?
Initially, the contralateral limb should be applied, and then when the pain is lesser, then the affected limb can be used.
In acute pain, when there is hyperalgesia, allodynia, patient would not be able to tolerate the current intensities which are given in TENS. I think starting it should be when the pain is around NRS 4 to 5, when patient can tolerate. I think then it should be started, right?
Right, the pain control is very important, and the contralateral limb we can use for the application.
Thank you, ma'am. Thank you.
Okay.
Welcome.
Yeah. So with this, I think we should conclude. Thank you, Samriddhi ma'am. Thank you.
I think there are a couple of questions also they've recently asked.
Yes. So, is there any role of hyaluronic acid? Injection of hyaluronic acid? I think there is no role, right? So it's basically a lubricating agent which should be given in arthritis and all those conditions. CRPS is totally different. I guess there is no role. Am I right?
Absolutely, absolutely. So the pathophysiology actually speaks of the mediation of the pain, right?
Yes.
So it starts from a peripheral sensitization and it gets coupled with the sympathetic maintenance. So basically, it's a neural condition. So anything that has to do with the mechanical interruption of a mechanical space, just like a hyaluronic acid is used in an intra-articular space, that I don't think can help. That can never help a CRPS patient.
I think there are no more questions.
Sir, there is a question on role of Botox in CRPS.
Good. So, Dr. Preeti, is there any evidence for that? For Botox?
Though evidence is lacking, but yes, there is increasing use of Botox, and the RCT is needed for the formulating the evidence.
Currently, there are no definitive guidelines or evidence for Botox.
Ji.
Right. And okay. Finally.